Congenital nephrotic syndrome. Nephrotic syndrome below 3 months is called congenital nephrotic syndrome. Basically, they are mostly genetic. 70 to 85% of the congenital cases are genetic. And primary CNS congenital nephrotic syndrome, they account for the genetics good amount of cases. These genes are the nephrin and NPHS1, protosin 2 and 3, the your PLC, and WT1 gene is responsible for the Danish-Dresch, Walker, and Frazier syndrome. LAMP2 gene is responsible for the Pearson syndrome, maybe isolated to nephrotic syndrome CNS, and then your LMXB1B nail patella, and WD73 Galloway Moet, and Q10, and a few more. There are 90 genes said to be involved in the pathogenesis of the congenital nephrotic syndrome and your SRNS. And as I said, some of the genetic cases, some of the SSNS may have this. 11% in adolescent nephrotic syndrome, or even your 18% of the your child, grown-up child nephrotic syndrome, they do have underlying genetics. So, how do you treat congenital cases? Apart from the genetics and the small subset of cases, you might have infection, underlying infection. Then you have maternal diseases like lupus, a maternal antibody, NAP autoantibody formation, maternal steroid and chlorpheniramine maladies, and so thereby a torch infection of the mother and the baby should be looked upon. The infective cases may respond to the infective therapy. Some of the old cases with fibrosis, they may not respond with the TORS, cytomegalovirus, rubella, your other viruses, herpes, hepatitis, and your even malaria, your maybe syphilis. Once upon a time, very common. They were underlying causes, so they should be treated in standard fashion. So, how do you really have the disease? You have preterm low birth delivery. May have preterm low birth delivery. You may have your last placenta more than 25%. You may have your most of the time 80% or so your diagnosis of nephrotic syndrome, massive proteinuria, hypoalbuminemia, edema, everything by 80% of cases by 2 months or so. And there can be a little bit of brain involvement, a good amount of renal diseases, notably the nephrin, they have the brain involvement, systemic disease, genetic disease, and there may be mild brain atrophy, dystonic sort of cerebral palsy, mental retardation is possible. A small subset of cases there can be pulmonary stenosis. So WT1 Walker syndrome means in the Wilms tumor, aniridia, genitourinary amylase, and mental retardation. Other subset of the WT1, they do present as the Danish-Dresch syndrome, presenting as the XY phenotype, basically in a male, and presenting with female, so pseudohermaphroditism. They may have Wilms tumor in the long term. They may have gonadoblastoma, dysgenesis, and thereby the preemptive nephrectomy at times is advocated. And Frazier syndromes are the males, again, males with hermaphroditism, gonadoblastoma. They also have your high risk. Thereby again the preemptive nephrectomy. And diagnosis of these cases is by genetic study. So, a child presenting with nephrotic below 3 months, you always go for the whole exome sequencing of the child. And if you do found in a high percentage of cases, 70% on an average, you don't give steroid immunosuppression. They really do work. So, thereby treatment is basically your supportive, IV albumin infusion, your antibiotic for infection, IVIG, your calorie nutrition by gaseous or tube feeding, even gastrostomy, and give the immunosuppressant, your antiproteinuric drug like ACE inhibitor and ARV. Then finally you wait for the secretive progression, and if you don't have that, you go for the CAPD or preemptive transplantation. You should have 10 to 15 kilo weight for the transplantation, and find out a non-genetic donor. And and it may take few years, 2 to 4 years or something. And when you have these things, difficult journey, difficult course, but at the end of everything you may have little bit of happy outcome in some of the children of these CNS cases.